Evening to all. And thank you, Manish sir, for making my work so simple, but yet that's only the one part and one side of the coin. So before I start the presentation, I would like to thank Team Ajanta and Rajul sir and Shefali ma'am for making me a part of this academic event. So as sir said that I'm an institutional person, but that doesn't change my choice of surgery or my choice of treatment for my patient. So now if we talk about the primary angle closure glaucoma, let's see that what my stance is going to be when I look at the literature as very well discussed in the previous lecture, but still there are many more things to take from the evidence too. So if you look at the profile of this particular gentleman, demographically, he's a middle-aged, active life living individual who is requiring 3 topical IOP lowering medications despite that he is having a post laser PI. Along with that, coexisting morbidity, ocular morbidity in the form of cataract is there with him. So then, what's the confusion? The evidence says that whether you can go for a phacoemulsification or you can go for a combined surgery too. The debate here is that phacoemulsification, my stance would be, won't suffice here because the medication burden is already maximal. And we know the nature of the disease, it's chronic, gradually progressive in nature. So that means we need to look beyond the lens extraction. Now, coming back to the case scenario once again, patent PI 3 AGMs. That means it indicates a persistent closure mechanism. Coming back again to the demography, middle-aged individual definitely must be leading an active life. That means it necessitates a aggressive long-term preservation, not only of the vision, but to provide a good quality of life is also a double added responsibility on our shoulders. So for that, to understand what I just said, we need to go back to the basics where we know this particular slide has been taught to us from the very core, from the very basic, that angle closure glaucoma or the disease is always a disease of overlap. Could be not. So always we have to give it a benefit of doubt because if we talk about surgical rationale, choosing of the surgery, we all know this particular photograph. It's a very common, used everywhere. So if we talk about lens removal, definitely it would be taking care of part that is pupillary block component caused by it. But what about the other things, the compromised trabecular meshwork, or are we going to get a sustained IOP with a sealing good effect? The answer is no. What I just said, I would substantiate with a meta-analysis done by Lenau et al., who said that the IOP reduction is definitely going to have an upper edge, having superior and significant reduction in IOP when it was compared with the phacoemulsification alone in the angle closure glaucomas. And similarly, we all know, going back to the disease nature, the pocket burden to the patient, because it's a lifelong disease, you have to take care of the pocket too. So now the medication burden also was reduced to a larger extent when a combined surgery was approached. And how can we forget this particular aim which we have been grown up learning glaucoma practices? It's not only about preserving the vision, but it is providing a good quality to our life. And I'm sure that none of us sitting in this hall would ever agree any drop, even if it is a single bottle, you have to use it continuously. Sometimes you tend to forget it or not to use it. Then why are we debating? So, because still I reiterate and re-emphasize that phacoemulsification for the angle closures are not sufficient, especially when we talk about the pass, which could be, which may not be in this particular case, but patent PI 3 AGMs, mind you, the disease is progressing. The damage to the outflow is already existing. And when we operate this case, the desired target IOP would be less than 15, which might not be attainable after a couple of years or months together. So the predictability here, we need a robust fail-safe pressure regulation mechanism, which is definitely we are going to achieve with the help of combined surgery. And yes, we always look forward as what world is saying, where world is moving. So the WGC 2026 consensus says that the decision has to be a patient centric while taking any decision, because we have been taught that whenever you take any decision, make a patient party to your decision too. So you have to keep a balance between the ocular health against the procedural complexity. Having said that, going back to the evidence once again, and talking about a meta-analysis done by Zai et al., who said we all know as a glaucoma surgeon that the initial 1 month post-op is really important for any of our patients, whether it's about the fluctuating IOP, it's about maintaining the pressures, whatever it may be. And they found that in initial 1 month in the phacoemulsification group, there was a significant high IOP was found. And we know that a patient on 3 AGMs, we cannot afford to have that because definitely the disease would be in a moderate stage, ONH would be compromised. So our case, we have already said that early stabilization of the IOP is of paramount importance. Now, the medication dilemma, what we have been talking about so far, of primary goal for a 55-year-old patient is definitely the reduction of a long-term polypharmacy. So now coming back to my schooling, my teaching again about glaucoma, this was the particular slide which we've been taught about while taking a decision when we didn't understand much of glaucoma was if PAS is more than 180 or you have a disc and visual field changes, opt for a combined surgery, which is being supported by the literature too. So now the rebuttal talking about the safety issue, because it's always said by the critics that phacoemulsification should be opted because it's much simpler and I can say that it is associated with lesser number of complications. However, in a glaucoma patient, in a chronic progressive disease, never the safety should be isolated metric. It's much beyond that too, because the visual field loss, because we know in angle closure glaucomas, the main concern is not about only the pressure control. It's about the fluctuation of the IOP, which needs to be monitored and catered. And that can be taken and dealt carefully only when we approach the patient with a combined surgical approach. Now, already on 3 drugs, we have already discussed that the disease could be of aggressive or advanced stage, and a combined procedure with the modified core techniques and many more techniques, they are having a better edge to normal surgeries. Now, this 55-year-old individual, the poor complex cannot be forgotten in his busy schedule. We cannot expect him to continue using the drops. And also the ocular surface health of paramount importance. He will grow gradually. The ocular surface is going to get compromised. So the things we should avoid here would be, in this particular case, would be early post-operative spikes, frustration of continuing 3 drops in a 55 individual, and a secondary, more unpredictable, because as very well said my co-debater, that it can be done as a second stage or a third stage procedure. But what about the conjunctival health?
Please wind up.
Last slide. Last slide. So the conjunctival health is going to get compromised with the AGM, and that will affect your trabeculectomy results too. So summarizing my main points and re-emphasizing what I just said is a combined phacotrap is a prudent evidence-based choice for a durable long-term control of disease. Though phacoemulsification may be safe, but the combined surgery always offers a superior long-term control for the patient already failing maximum medical therapy. Thank you very much for your patient hearing.